Welcome to the IMSAN Malignant Hyperthermia Clinical Protocol video. This guide is designed for anesthesiology, PACU, and surgical teams to ensure readiness and rapid response. Malignant hyperthermia, or MH, is an acute hypermetabolic crisis triggered by specific anesthetics in susceptible patients. It involves a massive intracellular calcium overload leading to muscle contraction and heat. Effective preoperative identification is vital. Screen for patient history, including central core disease or muscular dystrophy, and family history of anesthesia complications. If MH is suspected, do not operate at IMSAN. Transfer immediately. Know the anesthetic agent matrix. Volatile anesthetics and succinylcholine are major triggers and are contraindicated. Safe alternatives include local anesthetics, propofol, ketamine, and rocuronium. Recognize the tipping point of a clinical presentation. Watch for sustained jaw muscle contractions, tachycardia, tachypnea, and dark tea-colored urine, which may indicate metabolic or respiratory acidosis. Do not wait for a fever. The leading indicators are a spike in end-tidal CO2, decreased oxygen saturation, and tachycardia. A rise in temperature is often a late sign. Upon a code blue declaration, execute 3 concurrent action tracks: halt triggering agents and ventilate, prepare the Dantrolene line, and provide systemic support. OVD team members must immediately dispatch the manifest, bring the MH kit, cooling supplies, a backup anesthesia machine, and the standard code blue cart to the operating room. Track 1 focuses on stabilizing the patient. Switch to TIVA, hyperventilate with 100% oxygen at 10 liters per minute, secure the airway, and halt all patient warming systems. For the Dantrolene assembly line, assign 2 staff members exclusively to prepare the drug. Reconstitute each 20 milligrams vial with 60 milliliters of sterile water and administer the initial 2.5 milligrams per kilogram dose. Track 3 involves systemic support. Insert large bore IVs, a urinary catheter, and a gastric tube. Initiate aggressive cooling if the body temperature exceeds 40 degrees Celsius. Manage complications like hyperkalemia or arrhythmias with appropriate medical intervention, but remember the critical warning. Never administer calcium channel blockers, as they can cause cardiovascular collapse. Be aware of potential side effects from treatment, such as muscle weakness from Dantrolene or fluid overload. Handle Dantrolene carefully, as it is alkaline and can cause skin irritation. Finally, ensure post-crisis stability. Coordinate the transfer to a higher level of care, continue monitoring, and complete all required documentation and incident reports immediately.
Welcome to The Explainer. Today, we are opening up a genuine medical crisis playbook. We're looking at the absolute granular details of the IMSAN Malignant Hyperthermia protocol. Now, this isn't just medical theory. This is a highly choreographed, incredibly high-stakes emergency response where literally every single second counts. So let's dive right into this and see exactly how a hospital prepares for an event that strikes with practically zero warning. Here's our crisis playbook for today. We'll start by uncovering the hidden threat. Move on to recognizing warning signs, activating the protocol, administering the antidote, and wrap up with the aftermath and reporting. It's basically the chronological journey of a life-or-death operating room emergency.
Section 1. The hidden threat. A genetic time bomb in the OR.
Okay, so the absolute crucial point here is understanding the underlying mechanism. Malignant hyperthermia, or MH, is an autosomal dominant inherited disorder. Basically, there's a defect in the sarcoplasmic reticulum inside the patient's muscle cells. When that patient is exposed to certain anesthetic drugs, there is a massive reduction in calcium reuptake. Imagine a microscopic floodgate suddenly bursting open. This leads to a massive, uncontrollable spike in intracellular calcium. And the result? The patient's muscles go into the state of continuous, non-stop contraction. This triggers a hypermetabolic crisis, generating a literally lethal amount of internal body heat.
Now, you might be wondering how common this is. It's incredibly rare. We're talking just 1 in 15,000 anesthetics in children and about 1 in 50,000 in adults. But because it's so rare, preoperative vigilance is just absolutely vital. The protocol dictates that a history of muscle diseases, things like central core disease, or prior unexplained red flags like dark, tea-colored urine, which is a major sign of severe muscle breakdown, well, those are massive warning signs. They demand the surgical team's utmost attention before the patient ever even goes to sleep.
Section 2. Recognizing the warning signs. Identifying triggers and clinical symptoms.
And that brings us to the pharmacological catalysts.
Anesthesiologists have safe options. They can absolutely rely on medications like propofol, the muscle relaxant rocuronium, and standard local anesthetics. But if a genetically susceptible patient is exposed to contraindicated triggers, specifically volatile anesthetic gases like sevoflurane and halothane, or the depolarizing muscle relaxant succinylcholine, well, the internal fire is instantly ignited.
Once triggered, the surgical team has to recognize the early warning signs instantly. There's no time to second guess. The very first clue on the monitors is often a sudden spike in end-tidal CO2, right alongside a sudden drop in oxygen saturation. Physically, the patient experiences increased muscle tone. Actually, sometimes the jaw muscles will suddenly clamp completely shut in a sustained, rigid contraction. The heart rate rockets to a dangerous tachycardia. We're talking between 150 and 200 beats per minute. And then comes the namesake symptom, a rapid, completely unexplained rise in body temperature. At this exact moment, the team knows the crisis has begun.
Section 3. Activating the emergency protocol. Code blue in the operating room. So, the IMSAN protocol outlines this rapid-fire sequence of critical actions to halt the progression. Step 1. Instantly stop the administration of any triggering anesthetics. Just cut the gas. Step 2. Seamlessly switch to TIVA, that's total intravenous anesthesia, to keep the patient safely sedated. Step 3. Call the anesthesiologist immediately for backup. And Step 4. Stop the surgery as soon as physically possible. In a matter of seconds, the primary goal has completely shifted from completing a surgical procedure to pure, unadulterated survival.
The fast-paced sequence continues with immediate physical interventions. Step 5. Instantly turn off any patient warming systems and begin actively measuring core body temperature. Step 6. Request the code blue crash cart and the dedicated malignant hyperthermia kit. Step 7. And this is wild. The protocol specifically tasks cleaning staff to frantically collect 2 massive containers of ice. And Step 8. Hyperventilate the patient with 100% high-flow oxygen at 10 liters per minute. The team is basically blasting high-flow oxygen into the lungs while physically scrambling to chill the room and the patient's body.
Section 4. Administering the Dantrolene antidote. A logistical race against time.
Now, the sheer scale of resources required to administer the antidote is massive. You don't just push one little syringe. You need 12 vials of Dantrolene, 12 massive 60-milliliter syringes, and 12 vials of sterile water. Plus, you need 2 large-bore IV lines inserted just to pump that sheer volume of fluid in. And here's the kicker. Dantrolene is incredibly difficult to dissolve, so the protocol mandates assigning 2 dedicated, qualified staff members whose sole job during this entire crisis is to furiously mix 60 milliliters of sterile water into each individual vial.
Once it's finally mixed, the mechanics of administration have to be extremely precise. You administer the Dantrolene at an initial dose of 2.5 milligrams per kilogram of body weight pushed slowly over 1 to 2 minutes. This specific medication works directly on the muscle cells. It forces them to relax and halts the catastrophic hypermetabolism. If the severe symptoms persist, well, the team has to repeat this exact, exhausting dosing process every 5 to 10 minutes.
Let's anchor the massive scale of this intervention with this number, 800 milligrams. That represents the maximum cumulative 24-hour dose for an average 80-kilogram patient. Just think about the exhaustive physical effort required by the OR staff to constantly mix and manually push that much medication, all while simultaneously managing a crashing, highly unstable patient.
Section 5. Aftermath and critical reporting. Stabilizing the patient and ensuring accountability.
So, the acute fire might be out, but the metabolic fallout from the crisis is severe. The team has to maintain active cooling by removing blankets, applying all that ice, and using cold IV fluids. They have to urgently treat hyperkalemia, which is a spike in potassium levels that directly threatens the heart, by administering insulin and glucose. They must counteract severe metabolic acidosis with sodium bicarbonate, and importantly, they have to prep for rapid transport to a higher-level care facility like the HOH to save the patient's kidneys from the massive muscle breakdown that just occurred.
Extreme vigilance is required in the aftermath. Using the Malignant Hyperthermia monitoring chart, the team has to meticulously track the patient's end-tidal CO2, pulse, and temperature, literally minute by minute, because even after Dantrolene is given, a patient can easily relapse. It happens. The monitoring chart acts as their vital radar to catch a second spike before it becomes fatal.
But, the protocol's job isn't finished just because the patient is transferred out.
Strict administrative reporting is an absolute requirement here. The anesthesiologist must complete the comprehensive MH form, document the entire event in the electronic patient record, file a VIM incident report, and directly notify the pharmacist to immediately restock that massive depleted supply of Dantrolene. This ensures absolute medical accountability and, of course, continuous safety improvements for the hospital.
So, I want to leave you with this final provocative thought. If a seemingly routine surgery can suddenly demand 12 vials of a rare antidote, massive containers of ice, and a highly choreographed emergency response from every single person in the room, how prepared is your local operating room? Understanding the intense anatomy of an emergency like malignant hyperthermia really makes you deeply appreciate the rigorous, life-saving protocols these medical professionals master. Thanks for joining me on this explainer, and stay curious.